So let's now go to our second plenary, and what a plenary we have for you. We have Professor Ramani Moonesinghe from UCL, who's a true leader in anaesthesia research. Before COVID, she was directing the Health Services Research Centre at the Royal College of Anaesthetists, leading studies which, if you've ever tried to recruit for a clinical study yourself, will make you weep, because she managed to recruit for the SNAP-1 study, for instance, 15,000 patients in 2 days in 97% of UK hospitals. Respect, Ramani. I mean, extraordinary. But when COVID arrived, Ramani was promoted to National Clinical Director for Critical and Peri-Operative Care, which I think most of us would very quickly file under T for tough gig. Today, she brings us some of the lessons that she's learned and about how to capture the learning that's come from COVID and the role of research in supporting improvement in the future. Ramani, over to you.
Hello, everyone. My name's Ramani Moonesinghe. It's a delight to be here today to talk to you about innovation in the time of COVID-19, and thank you to Mary and to this institute for the invitation to give this talk. My normal job is as a professor of perioperative medicine and a consultant anaesthetist at University College London and University College London hospitals. But like everybody else, I've been working a little differently over the last few months, and my main work has been as National Clinical Director for Critical and Perioperative Care for NHS England and NHS Improvement. And so it's that role that I'm going to reflect on today when I give my thoughts about innovation in the time of COVID-19. So we've had to do a lot of innovation over the last few months. Everybody's recognised that. And as far as critical care is concerned, we've had to think about the stuff that we use, so the equipment, the consumables. We've had to think about how we look after and use our workforce most effectively for this enormous challenge that we faced. We've had to think about the space that we occupy in terms of looking after critically ill patients. And we've had to think about some of the structures, so the physical structures, the infrastructure, guidelines and practice, and how all of that needed to adapt in order to meet the COVID-19 challenge. So looking at the critical care lens, I suppose first of all we need to reflect on how we were before COVID hit us. And we've had a few problems in the NHS over the years in terms of critical care capacity, which have been covered quite extensively in the newspapers and in the medical media as well. So we often, particularly in the winter, have small or large crises in terms of intensive care capacity. And that was our baseline position. And that can and has affected the way in which we've looked after particular types of patients. And in particular, as I've said before, my role as a perioperative physician and anaesthetist, it's caused us to think a little bit about how we look after patients having major surgery. So this study that we conducted a few years ago looked at the rates and reasons for cancellation of major inpatient surgery in the NHS, and found that 1 in 10 patients having a planned major operation had been previously cancelled at least once. And if you look at the risk factors for cancellation, the requirement for a post-operative critical care bed was the biggest risk factor for being cancelled at the last minute for non-clinical reasons. So it's clear that critical care was a pinch point in the care of the high-risk surgical patient, and obviously that then overflows into the care of all patients requiring critical care. And of course, there are clear reasons for why that might have been the case. This, taken from an open access website, shows you that the number of critical care beds per capita, so per 100,000 population, in all of these countries, both high income and middle and low income countries. And you can see there the United Kingdom down there towards the bottom with 6.6 critical care beds per 100,000 population. Compare that with the United States, which has nearly 35. Now, some of that difference is down to definition. The definitions of critical care in different countries are not the same. But nevertheless, there has been a feeling that the UK has had fewer critical care beds than many other parts of the world for some time. And when you then try and cast your mind back to the beginning of March or the end of February in this year, before the lockdown, before we really understood that much about how the virus was transmitted, we got this prediction from Imperial, which really changed the course of the way that the pandemic was handled in the United Kingdom. And This is a graph that's taken from the Imperial paper published in the middle of March 2020, and it showed the likely impact of different non-pharmaceutical interventions, so public health interventions, on the likely incidence of the virus and the impact it would have on critical care beds. So this is a graph specifically looking at critical care beds. You see that very tall peak in the middle there is the do nothing scenario in terms of the number of critical care beds required per 100,000 population. You can see that's around 275. The horizontal red line at the bottom, which I've highlighted, is the number of critical care beds, even the surge capacity of critical care beds. So that's stopping all elective surgery, using operating theatres to provide additional critical care beds. And you can see that the number of beds that we thought that we would be able to provide compared with the do nothing scenario, we were going to be woefully short. And that's obviously one of the reasons why the social distancing, the lockdown and all those other things happened, was the intent to try and prevent the overwhelming of the NHS and the overwhelming of critical care in particular. And of course, up to a point that really worked. So what was the gap in the end? So thinking back to the four S's that I mentioned earlier, that's not my phrase that I've coined, that of colleagues of the Royal College of Anaesthetists. But if you think about stuff, critical care patients need loads of stuff. They need loads of equipment, loads of monitoring and all sorts of other things. If you think about space, so there's about 100,000 inpatient beds in the whole of the NHS, around which 4,000 are critical care beds. But of course, the impact of the virus wasn't going to be just on critical care. It was going to be predominantly on respiratory services and acute medicine services, because thankfully the majority of patients who get COVID-19, the majority don't get hospitalised at all, and the majority of those in hospital are in beds which only require oxygen support as opposed to critical care support. So, but the impact on therefore the whole health service is very significant. And also there is the need to try and continue to run some services outside of COVID-19, and I'll come back to that in a moment. We also need to think about the structures. So we didn't really know anything about the disease at the beginning of March, and we needed to rapidly advance our knowledge and develop guidelines and best practice around the treatment of these patients. And also the estates. So it's not just about the space. How much oxygen were we going to give patients, and how was that all going to be provided? And then finally, and most importantly, the staff. Critical care is a very specialised area of clinical practice, and we had chronic workforce gaps, and we were going to have to massively expand our workforce. So the challenge of doing that was really very, very considerable. So a lot of press has been, attention has been diverted to the ventilators. And the ventilators were a big story, because one of the things that happened at the beginning of March, end of February, was the realisation that we would need many, many more ventilators, or we thought we would need many more ventilators than were available. And the challenge was, of course, that ventilators are not sitting generally in warehouses waiting to be bought off the shelf. They're made to order. The lead-in time is usually 6 to 8 weeks. They're mostly made overseas. And of course, this is a pandemic, the definition of which is that it's a global problem. So the whole world was fighting for the same stuff all at the same time. The approaches to that were obviously to try and buy as many ventilators as possible, but immediate deployment and receipt of those ventilators was mostly not going to be possible for the reasons I've already articulated. So what would you do in that situation? You obviously want to buy as many as you can, but then what do you do if you can't get as many as you need? Do you make do, or do you make? The make-do option, really, one has to go back to Copenhagen in 1952 and the polio epidemic that was really the beginning of intensive care medicine as we understand it now. And when it was realised that a solution to the terrible muscle paralysis and therefore loss of airway reflexes and ability to breathe that affected people who got polio in the early 1950s, once it was realised that the solution to that was to essentially give the patient an anaesthetic, put a breathing tube in, and then support their breathing. What then happened, because there were no ventilators at that time, is that people would sit like this physician did there. That physician could easily have been a medical student, because that's what medical students were asked to do in Copenhagen in 1952, sit at the bedside and bag, you can see in the right hand of that gentleman there, bag air and oxygen into the patient. And medical students did shifts where they provided this service 24 hours a day, 7 days a week, to the people that were affected by polio, and it caused a massive improvement in lives saved. However, in this scenario here, there are some real challenges to that sort of approach. Would you have the number of people? Would you be prepared to put them at risk of contracting the virus themselves? And one of the questions that was asked is a bad ventilator worse than no ventilator at all? Because it was clear that the best high-functioning ventilator was not going to be deliverable in the 2 weeks that we thought that we had, 2 or 3 weeks before the virus peaked. So what was the risk of not trying to make ventilators and buy them at scale? The risk was potentially to personnel. You didn't necessarily want medical students sitting at the bedside exposing themselves to the virus. There's also risk to patients, because actually bagging air and oxygen into a patient isn't really that good for them. There's lots of ways in which that can go wrong. And of course, if you don't have enough equipment, then you've got the ethical dilemma of who you do give the equipment to. And that was a situation that we definitely want to try and avoid. So the solution to that was, of course, innovation. The innovation in this situation was the ventilator challenge, as it was called. And so a specification was developed for a rapidly manufactured ventilator that would potentially be deliverable within a few weeks rather than a few months. And the speed with which that progressed was quite astonishing. On Friday, the 13th of March, the first specification was written. The government decided to go with this challenge. Industry was called to arms over that weekend, and on Monday, the 16th, a clinical team was assembled to try and review the devices as they started to come through in terms of the specifications and the designs. An initial meeting of manufacturers occurred that Wednesday. A testing protocol was agreed that Thursday, and then everything was full systems go. And it really was an extraordinary endeavour on the part of industry, as well as on the part of the clinicians that supported the endeavour, and all the other many people involved. What's the outcome of that? Well, this is now openly available through a National Audit Office report investigation that's been conducted into this whole thing. A huge number of ventilators were purchased, around 20,000 mechanical ventilators and non-invasive ventilation machines. And through the challenge, about another 25,000 ventilators have been made. That's all come at quite considerable cost, as you would imagine. The cost to the general public, to the public purse, has been around £400 million. And the evaluation of the programme so far has been fiscal only. But the clinical evaluation, we're still right in the thick of it, because, of course, this pandemic hasn't gone away, and these ventilators are now being used. And one of the things that we're really turning our attention to now is the safety of deploying lots of machines that people are not necessarily familiar with at scale, all at the same time, developing guidelines and developing the training to make sure that everybody who receives them can use them safely. What other innovations did we see? So innovation in pathways and practice is clearly a massive innovation, and huge numbers of guidelines were developed at national level, regional level and local level, covering not just the treatment of patients with coronavirus, but also how we look after all the other patients in the NHS that needed care during this time of unusual activity. And for me, one of the extraordinary changes has been the development of the preprint endeavour. So preprint servers existed before, of course, but most people didn't put their research on preprint servers. They go to journals first, and they go through the peer review process, and then they're published in journals in a process that we all know and understand. But we will all recognise now that all of the big papers that have been published describing big changes in treatment, randomised trials, evaluations of all sorts of different things, have largely been published on preprint servers before they've been published in journals. And that's, for me, a major change, and one that we want to really think about. In terms of clinical practice, we had to rapidly evaluate. At the beginning of March, my impression anyway was that this was almost entirely a renal disease, but it became very clear that it wasn't. This is fantastic data that's come from our national audit of intensive care, run by the Intensive Care National Audit and Research Centre, ICNARC. Now, on the left, the table is data from the financial year 18-19, showing the proportion of patients and the number of days of support of renal replacement therapy. So this is hemofiltration, this is continuous replacement, taking out the blood, washing it and putting it back in again for patients whose kidneys don't work. And you can see there that around 10% of admissions in a normal year would receive renal replacement therapy, and that accounted for about 95,000 patient bed days. Now in COVID, on the bottom right there, you can see the proportion of patients who required renal support in the first part of the pandemic up to the 31st of August, and it was nearly 27%. So 10% compared with 27%. And you think about that in the number of days of renal replacement therapy that was required. So around 38,000 days of renal replacement therapy was required in a month in just England over the peak period. And you compare that to about 95,000 days across the whole of the United Kingdom in a year. And that has a big, big impact on the amount of stuff that you need to support patients having renal replacement therapy, because hemofiltration requires fluids, which are single use only. It requires these things called filters, which facilitate the washing of the blood that I've described, and they are single use only. And the patients that have COVID, you will have also had, tend to have quite hypercoagulable blood, so sticky blood, and that causes problems for the machines and the filters, which means that we use more than one might normally predict one would use in a patient who didn't have COVID. So what that meant is that all of this stuff that was being consumed at a much, much higher rate than normal, which meant that there was a real risk that it was going to run out, and therefore we had to innovate again. And the innovation was in the form of developing guidelines that would mean that you could use this resource more carefully, but still give patients the best quality of care available, and also use different types of renal replacement therapy. So using forms of dialysis rather than filtration, and intermittent hemofiltration. So doing it for a day and then giving the patients a break so you can use the machine on a different patient. All that sort of thing happened at pace, that level of innovation, in a way that is very, very unusual, I think, in the NHS on a normal day. Workforce was our other big constraint. Our doctors, our nurses, our allied health professionals are, of course, the NHS's most important resource. Now, at that time, at the beginning of March, where we thought that we were going to have to look after 18,000 ventilated patients at the peak, we then thought, well, we've got 18,000 ventilated patients that are going to need care all at the same time, and we've normally only got staff for about 4,000 ventilated patients. So what are we going to do there? And we had to rapidly draw up mitigation for how we would split the nursing and medical workforce and the allied health professional workforce to cover this massively, massively increased workload. And you can see the potential compromises that we thought we were going to have to make. So usually an intensive care patient has one fully trained, experienced critical care nurse sitting at the bedside with the patient, doing everything that that patient needs, looking after the ventilator, looking after the hemofilter if they need one, looking after all the drugs they're on, and very importantly, looking after the patient themselves from a holistic perspective and the relatives. And we thought that we were going to have to dilute that ratio of critical care nurses from 1:1 down to 1:6. And in terms of doctors, similarly, we thought we were going to have to massively dilute the experience of trained intensivists. So normally you'd have about one trained intensivist for every 10 patients on the unit. And we thought we were going to have to dilute that down to 1 in 60. And we would have to supplement that workforce with workforce taken from other parts of the system. So reservists, so doctors and nurses and allied health professionals who'd recently retired or for any other reason had left the health service were encouraged to return, and more than 5,000 doctors alone came back under that scheme. And also redeploying staff from other parts of the system, so surgeons, anaesthetists who don't normally do critical care, nurses working in all sorts of different areas of the hospital, were redeployed, were rapidly trained to provide support services to critical care, so that there at least could be one person at the bedside, even if they were not a fully trained critical care nurse, and that fully trained critical care nurse would then be able to use their skills across a number of different patients. And that, you will imagine, created an enormous challenge in terms of training and innovation again. We know now that COVID-19 is not just a respiratory illness. These critically ill patients have multi-system disease that can at times be unpredictable. they have coagulation and cardiac problems, they have renal problems, as I've already described. And that has huge implications for practice, but also for policy and strategy. The stuff that we buy, I've already articulated, but also the mechanism for expanding services. Again, a lot of attention was given to the Nightingale hospitals, and most of the early Nightingale initiatives were focused on providing additional critical care capacity. And two things changed over the course of the first part of this pandemic. The first was, thankfully, that Armageddon-ish, I guess, prediction of the number of critical care beds we would need didn't materialise, thankfully, largely down to the success of the public health measures and the success of the public adhering to them, for which, of course, we are all enormously grateful. But the second thing that materialised was the fact that these patients are, as I've already just said, more complicated than just having single organ respiratory failure, and therefore it's possible that if we do use the Nightingales, that they will be used, at least some of them, less for critically ill patients and more for other things. The structures had to change rapidly. So on the 17th of March, a letter was sent out to all hospitals talking about how we had to redeploy staff and free up as many beds as possible and as many staff as possible to look after COVID patients. And we did need last time to rapidly create this capacity just in case we needed it, and also to enable general sort of pandemic preparedness. So none of us knew how to put PPE on smoothly in a way that would protect us at the beginning of February, and everybody had to know how to do it by the middle of March. And part of preparing for all of this meant that the tap was switched off in terms of other services. Right now, of course, hospitals are returning to elective work, and the ambition is that over the course of the pandemic, over the winter, whatever happens, that we will try to continue as much elective work as we possibly can so that patients with non-COVID diseases and conditions can continue to receive the best possible care that we can give to them. So what are we trying to address in order to make all of this possible? Expanding and making best use of critical care facilities through capital investment, it's investment in buildings and so on, and also paying attention to equity of opportunity and issues of deprivation, so trying to give more to regions that have traditionally had a bit less, and to try and stepwise step down the other work, the non-COVID work, so that we don't just switch off the tap this time. And in terms of doing that, therefore, use our workforce across all the different things that we have to look after as wisely as possible. So what do we want to keep in terms of the things that we innovated in last time, and what do we want to really properly evaluate in order to learn from the lessons over the last 6 months? I think everybody watching, listening, thinking about this will recognise the enormous speed with which research and innovation has happened. I've articulated a few small examples here, but it's been the same across the board. And one enormous success has been how quickly research can be delivered. So going from ideas to setting up the infrastructure, to getting through ethics, to getting through R&D approvals, and then getting the first patient recruited, those processes have been massively accelerated. And that's been an enormous benefit to learning how to treat this disease in the best possible way. We've had to adjust the structures that we use in order to enable rapid knowledge mobilization. So for example, the preprint process, I'm very interested to know whether actually undertaking peer review does make a major difference to the results of research. We've taken on the whole preprints as evidence when we've needed to rapidly change practice. So does the preprint, is the preprint enough? Do we need to go through the peer review process? And I'd be interested to know if anybody is evaluating the impact of the peer review process on the messages that we get from research. Rapid access to audit and QI data. So the data I showed you from ICNARC earlier, which described the scale of the renal replacement therapy problem, it was only through seeing that data that we were able to recognise the fact that renal failure was a much, much bigger problem than we'd previously anticipated. And therefore we were able to change strategy in terms of how we delivered that care and what we bought in order to support that care. We've seen a massive loss of bureaucracy, and we have to ask ourselves why it normally exists. Obviously, some of it is around financial accountability and personal accountability, and of course, safety. And we generally need to seek consensus when making change, and that takes time. But the question that we've got to ask ourselves is, can we improve this? Can we improve the time that it takes to reach consensus and therefore affect change in practice? And of course, we definitely want to keep some of the innovations. So some of the new pathways which have been developed, some of the new ways of working are really, really important. And one of the things I think we've really got to try and remember to keep is a little bit of tolerance of failure. Sometimes the biggest barrier to innovation is the fear of failure and the fear of being perhaps ridiculed. And we lost that because, of course, everybody was working with the same intention. And I think that's something that we could usefully keep going forward. What don't we want to keep and what do we need to lose? Well, some implementation might have been too rapid. So, for example, there are some drugs that have become commonly used that we might think, as more and more research comes out, may not be useful drugs to use in the treatment of this disease. And it's, again, only through evaluation and research that we can continue to improve our practice as far as drugs and everything else is concerned. We can't go on forever focusing only on COVID. We've got to think about all the other diseases and conditions that patients in the health service and across the world need treating. And I think one potentially big problem is that urgent public health research is quite reasonably being prioritised, but that really is at the expense of other research. And that other research was deemed valuable once, and I'm sure is still valuable. And so how do we address that? One of the reasons that everything was so straightforward to try and do at pace is because everybody worked so much harder than they normally work. People were regularly doing 18-hour days, 7 days a week. They lost their work-life balance, and now everyone's exhausted. Things on which we've made great progress, Athena Swan type initiatives, paying attention to the fact that people have lives outside of their work, and they need to be able to protect those lives outside of work. There was a period of time that we said goodbye to all of that, and that's definitely not a good thing. It was particularly bad during lockdown when so many people had to look after their children as well as work at this great pace. And we need to go back to some of those guiding principles to make sure that everyone has an equal opportunity to succeed in the workplace. Empowerment is a hugely important thing that made a great success of the way in which we delivered care for COVID patients. But it's not always a good thing, and giving empowerment to everyone without any barriers at all can lead to fiefdoms and territorialism, and some of these checks and balances are really, really important. And perhaps for me, the most important thing that we lost was patient engagement. It felt like a lot of what we did in terms of research, in terms of practice changes and so on, happened without meaningful patient engagement. And we made such great progress in terms of engaging patients and public, and we need to go back to that. Now. So my final personal reflection on all of this: we know that COVID was and continues to be an enormous human tragedy, and that is the most sobering part of all of this, of course. But there was and there is some good stuff that has come out of that tragedy. The research and innovation, the pace at which it worked. The fact that we recognise that we are truly surrounded by truly outstanding people. We have a resilient, adaptable workforce which must be looked after. We have frontline clinicians, particularly non-critical care staff, that really put themselves out and really made enormous personal sacrifices. And the leaders as well, who perhaps less visible, but they all worked incredibly hard for this single common objective. And that is a great success and really very moving, I think. And will we be better prepared next time? Well, we're definitely going into this winter much better prepared to look after patients with COVID. And I'm confident that we should get really good outcomes as best as we possibly can compared to the rest of the world for the patients that we have to treat in the NHS. And the other stuff, who knows? The next pandemic won't be COVID. It'll be something else, and it'll present completely different challenges. And one of the things that we need to think about is how we learn from this experience to be prepared for the next completely unexpected emergency that we have to face. Thank you very much.
Ramani, thank you so much. And I know I would be remiss if I didn't thank you not just for a great presentation, but actually for your leadership and all that you did during that peak time of COVID, which was so desperate. But actually, you know, your impact right across the land has been extraordinary, and I suspect that it's been at great personal cost, and that you didn't see your family for a very long time indeed. But thank you. So there's so many things to ask you. Tolerance of failure, that was really interesting. One of the things that of course the ventilator challenge, one of the things you saw there was that people became incredibly invested in it, and then actually we discovered we didn't really need ventilators in quite the quantity that we had thought before. How difficult was it moving from people who had invested so much, which we often see as a big break in terms of improvement, when people become over invested, into moving into something else, CPAP and that kind of thing?
So the health service, the way that we treated COVID patients sort of evolved from focusing on mechanical ventilation through to focusing on CPAP and other devices. Interestingly, that's nearer to normal than one might imagine. Normally, if a patient comes in short of breath, requiring support, we would go through CPAP or other forms of non-invasive ventilation before needing mechanical ventilators. So from a clinical practice perspective, that shift was perhaps not as hard as it might have been. There is still variation in practice, and we're waiting for the results of clinical trials, which are trying to evaluate whether one form of early ventilation is better than another. And we eagerly await the results of those trials. But the change in practice was perhaps not as hard as if it wasn't going back to what we would normally do, if you see what I mean. In terms of the ventilators themselves, there were many companies and individuals who worked extremely hard on the design and innovation. And yes, of course, it will be hard for those who didn't make it through to the end of the challenge. Thankfully, that wasn't my role, was to look after them in terms of the way that industry was supported and so on. But yes, I mean, I think everybody valued the opportunity to try. I think industry valued the opportunity to try. And thankfully, as you say, the outcome of needing that extent of ventilators wasn't required.
Now, we've got a ton of questions coming in. One of the ones that's been asked many times is, it's been said that the innovation landscape is quite crowded at the moment. Any thoughts on how we balance the speed of adoption with faithful yet efficient evaluation and regulation, which is, I guess, the nub of this?
Absolutely. And of course, the way to do that is to do everything in parallel rather than in series. So as we design things, thinking about how we'll evaluate them, as we design things, thinking about routes to implementation. And I think for devices and drugs, even drugs, it can be hard, but for devices, that's relatively straightforward. But it's for clinical practice, it's for pathways that's really critically important. And I think particularly working under the increased stresses of something like COVID and the stresses that puts on the health system, thinking about those routes to implementation as you're designing things is the key.
Another question here is, do you feel that there's a risk in preprints that their findings can be overemphasized in the media? I'm possibly guilty here, let me put up my hand, and risk spreading misinformation, or at least spreading claims made with little evidence?
So I think there is that risk, without a doubt. And I think that particularly in this context, we're desperate for good news, or we have been. And it's easy to grab hold of a good news story and for it to be disseminated perhaps inappropriately. I don't think the current system is perfect. I don't think that the system that's evolved, where results are announced earlier than before peer review and are put on preprint servers and those are taken as fact, I don't think that's a perfect system. But I equally rue the fact that other diseases, which are just as important in the greater scheme of things, it can take months and months and months to go through a peer review process, even for the most efficient journals and individuals. So we've got to find a balance. I'm not quite sure what the answer there is, but I think something that perhaps accelerates the current processes of peer review would be useful. Okay,
another very good question here from Louise Lowcock. Hello, Louise. if we think new rapid grant application ethics processes are a good thing, how can we make sure that they stay and that we don't revert back to 20-page proposals? Do you know, I think there's a collective cheer at Louise's question there going around the country. Is there a need for some coalition or lobby to try and make this happen? You know, there are an awful lot of things that have happened, Ramani, that you really don't want to slide back. You know, we have shown we can do this quickly.
Yeah. The key thing in all of this is time. We made time by virtue of the fact that everybody worked 16, 18-hour days instead of 8 to 10-hour days, and so on and so forth. And that was because of this collective focus on this particular need. The only way to make that sustainable is to invest in the resources, i.e. the people that have to give their time to facilitate the peer review process, the awards processes, and so on and so forth, as well as the people that are writing the grants. So yeah, we do need to retain that. We do need to retain the speed and efficiency with which all research has been conducted over COVID. But the only way to do that is through investment in people.
I'm going to ask you 2 quick questions, so brief answers if you will. First of all, what workforce changes do you think might endure? That comes from Lisa Hinton.
I think that one of the things that has been really positive is re-emphasising the need to work as multidisciplinary teams, as opposed to the nurse does this, the doctor does that, the allied health professional does the other. It's always been there, but it's been reinforced in COVID. So I think that's something that will be reinforced. Also, guidance has come out about how we might, for example, facilitate enhanced care facilities in addition to intensive care and high dependency care facilities. And I think that will be a really positive change that was planned anyway, but has been accelerated by the pandemic.
Now, I was cheering when you said about patient engagement. How has innovation for patient contact developed during the pandemic? Because we've heard about online contact for patients and relatives. Anything else that's being developed?
So, I mean, I think the main one is the online contact, and we've seen examples of that across the board, primary and secondary care. Again, I think faithful evaluations, they are going on, of course, to identify which patients benefit from that and which don't. It would suit me very well to have all of my consultations, medical consultations for me and my family online, but it won't suit my mother, for example, who's nearly 90. So that sort of evaluation is really, really important.
Thank you, Ramani. It's been a pleasure and actually a privilege, a considerable privilege to have this presentation. And thank you once again, not only for that presentation, but also for all that you did then and now. Thank you so much.